So chemotherapy is going to be the treatment via where we use drug therapy to treat the cancers. We use anti-neoplastic agents, and we will be doing treatment that is systemic. So we're giving this medication into their vein. We'll typically be using a central line, an implanted port or other form of a central line, and give the anti-neoplastic medication. These agents will destroy cancer cells in various ways and basically interfere with the cell functions and the reproduction of those abnormal cells. The goals of chemotherapy are really the same: cure, control, and or palliation, so it really depends. But the goals of chemotherapy have to be realistic, and they will determine, what medication is best, how aggressive of a treatment plan is feasible, what sorts of results that we're going to get from that. Thankfully, there's so much cancer research to really define all of these things, where they have lots of patients and patient data to say this chemotherapy is working the best for this type of cancer. This is the dosing, this is the length of treatment, and they have a lot of that information in addition to current trials. So patients can be a part of research trials. If they don't have good data on their treatment of their type of cancer, they could opt to be in a treatment study. Again, chemotherapy is really individualized. It's based on the type of cancer, the size, the amount of spread or metastasis, and the client's overall medical condition. And you could add here to the client's choice and the clients what they're thinking they want for their quality of life. Oncology nursing is really a specialty. So as nurse generalists, when we graduate and we take NCLEX, I would hope that they don't have crazy specific things on anti-neoplastic agents, because we would have to look them up to know exactly how this drug is working versus that drug, versus what are the most important side effects. We're going to focus mostly on a lot of the side effects of just all anti-neoplastic medications, but the next couple slides do talk about how these medications actually work. They talk about the cell kill and the cell cycle. There's basically 4 phases of the cell cycle, and you can see the RNA and protein synthesis, the DNA synthesis, the premeiotic, where the meiotic spindles forms, and then the cell division occurs with mitosis. Again, that's all very technical, not necessarily super important to the RN, but during the S phase is where the DNA synthesis is occurring, is where most chemotherapeutic agents work here. They interfere with the DNA and the RNA synthesis. So that's the bulk of where the medications that we're giving are actually going to be working to stop the cycle of the replication of these abnormal cells. Again, most chemo agents interfere with DNA and RNA synthesis, which is happening at that S phase. But one thing that I'll say is that repeated doses of chemo over a prolonged period are necessary. We won't necessarily get rid of 100% of the cells, but we'll get rid of enough so that the body's immune system can do the rest. So that is the goal. We might have chemotherapy every 3 weeks for up to 6 to 12 months, and we're going to just knock it down as best as we can, and then hope that our normal immune system can handle getting rid of the rest of the foreign cells that are there. Each time the tumor is exposed to chemo, anywhere from 20% to 99% of those cells are destroyed. So that really depends on the dosing and the type and how aggressive the cells are for replication as well. But every exposure is important. Even if a patient can only tolerate a couple doses, that wouldn't be the ideal full treatment plan, but that would be definitely better than nothing. Administration of chemotherapeutic agents. There are definite guidelines for administration that have been established by the Oncology Nursing Society. As an RN, if you're working in this specialty area, you can get your separate certification for oncology nursing, which would be additional training and education and very helpful, obviously, for your job and for your resume. There is a double check as far as physician orders via protocol, via medication amounts, etc. I know in our infusion therapy area, there was a pharmacist right on that unit, and he and the RN together, he or she, and the RN together review the dosage, the patient's weight, the patient's labs, allergies, etc., everything to verify the correct dosing, and then it is even appropriate to have the chemo administered based on their blood values, making sure they're not too immunosuppressed to go through with that particular scheduled day's infusion. So there is definite double checks on calculations and other labs and things. Again, as far as the PPE, personal protective equipment, many of the chemo agents are toxic to both the patient and the nurse. There'll be specifications as far as types of gloves, gowns, etc. that would be utilized. For sure, there will always be gloves, but some will also require gloves that are longer, that go up kind of up over the elbow, and or gowns to be worn. Again, IV, IM, oral agents, all routes are equally toxic, but if you're working as an RN in infusion therapy, you're primarily going to be doing the IV infusions. And again, there is special disposal of chemotherapy drugs as well. So many known chemotherapeutic agents are known vesicants. Vesicants mean that they're going to eat away, they're going to cause tissue necrosis if the IV were to infiltrate. So all medications can be hard on a vein or hard on tissue if it infiltrates, but those are non-vesicants. So vesicants are actual known drugs that are going to cause tissue necrosis if they were to infiltrate. And you see a couple pictures. Clearly, this can be very, very bad. So most chemo agents, and especially for sure if they are a vesicant, they wouldn't be allowed to be given peripherally. So we typically have patients, if they're undergoing chemotherapy, they're going to have more long-term treatment up to 6 months to a year or longer. They would typically have an implanted port placed, and we would be accessing that central line for their medication management. Some of the vesicants listed you'll see, adriamycin, vincristine, there are others. Again, we would always verify if it was a vesicant before starting administration. We will use the central line if possible. Again, with the vesicants, there'll be gloves and long sleeve disposable gowns that we would be using. Again, if we have extravasation, which would be infiltration of a vesicant or infiltration of an IV of chemotherapy medication, we would stop the IV, elevate the site, apply the cold compresses, and then call the doctor. They may inject an antidote. But again, hopefully this is not going to happen because we're going to be giving it through a central line, and we're not going to just even take that risk of infiltration of a vesicant. And then I just want to make sure that I clarified correctly on the last slide for administration of chemo agents. Again, with all of the double checking, knowing that the pharmacist is calculating based on the weight, so the body BSA, the body surface area, that's how they're deciding on the medication amounts, but also we need that height and weight basically to do that, to also calculate, so that would be something that the nurse would be assisting with when the patient arrives. Probably the most important slides here is, again, just as it was for radiation therapy, is understanding the side effects and the toxicities of chemotherapy agents. And more importantly, thinking about what the nurse would do for priority assessments and priority nursing interventions. So we do know that nausea and vomiting is the most common side effect of chemotherapy. Typically, it can occur anywhere from 24 to 72 hours after the administration of that dose. So if people are having problems with that, they will often pre-medicate with antiemetics prior to their chemotherapy treatment. There have been great advances in chemo drugs that a lot of them have lower and lower side effects of nausea and vomiting than ever used to, but that still can be an issue. Stomatitis is also that inflammation, irritation of the mouth, and again, those mouth sores are very, very common as well, along with the anorexia, nausea, vomiting, diarrhea, and just kind of all of those GI side effects. So with that, any antiemetics we talked about, small, frequent, bland meals, just real small increments, and fluids whenever we can get fluids down them, higher protein shakes and things, mouth cares, mouth rinses, the mycostatin statin or the nystatin mouthwashes can be helpful as well. As far as the hematology area, we think about fatigue and bone marrow suppression or bone marrow depression as being very, very common side effects of many, I shouldn't say all, of many chemotherapy medications. So those are very, very common. And again, with bone marrow suppression, again, the bone marrow is responsible for production of white blood cells, red blood cells, and platelets. So that patient would likely have what we call pancytopenia, which would be the reduction of WBCs, RBCs, and platelets. So with that, we have different medications. Filgrastim, which is Neupogen. Filgrastim is the generic name, would be injections to increase neutrophils, and that would help with that. Epoetin-elfin or Epogen, we've talked about that a few times. That will increase the red blood cell production. So those could be the injectables that could be used for treatment of side effects of chemotherapy, in particular the bone marrow suppression. Obviously, hand washing is very important, not wearing a mask, especially if the nurse was working and the nurse was sick. But hopefully, if you're working in that area, you're not coming to work when you're sick. Neutropenic and bleeding precautions, of course, and then monitoring hemoglobin, hematocrit, platelets, white blood cells with differential and all of that. Again, the importance of really looking at the absolute neutrophil count. They're going to be looking at the labs very specifically to determine if it is safe to administer that dose of chemo or not. As far as the renal system, renal toxicity can occur with many medications and many chemo drugs, so they're going to definitely look closely at the drug effects and figure out if excretion is an issue. They may want to monitor BUN and creatinine and make sure that everything is going smoothly with the chemotherapy drug that they have prescribed. So with any medications, with chemo drugs, we're going to be looking at other things, cardiopulmonary system, always watching for any signs and symptoms of heart failure, knowing what their pulmonary and cardiovascular function looks like, having a baseline vitals, baseline weight, lung sounds, and all of that would be very important prior to any IV infusion and any drug infusion of this type. So educate for signs and symptoms of heart failure or anything that might be a side effect. Again, each drug might have various differences, but we definitely want to have a baseline lung sounds, vitals, I's and O's, and daily weight. Reproductive wise, some of the chemotherapy drugs can produce sterility. So if fertility is still, depending on the age of the patient, if they are still hoping to bear children or have sperm for children, they may need to bank sperm or see other fertility resources for that. As far as the integumentary system, not as much as of a problem like radiation on the skin, but we would expect hair loss, so alopecia. Again, remembering to get them in touch with the American Cancer Society and other community resources for our cancer patients and wigs, etc. Neurological-wise, some of the medications can cause some damage with repeated doses to nerve endings and such, so they may end up with some neuropathies, some numbness, tingling, or even decreased reflexes. They will definitely probably develop more of a muscle weakness and loss of muscle strength, not so much from the drug itself, but just from the whole process of the cancer beating down their immune system and their nutrition maybe not to being as it is and not able to do the activity to keep their muscle strength up. So teaching them simple leg exercises and short periods of activity during their undergoing cancer treatment can be definitely helpful. And then just always making sure safety is in place as far as if they are feeling weak, dizzy, or having lack of sensation, that we would make sure that they weren't getting up alone. So if you were writing a care plan on somebody with cancer, it may depend somewhat on what type of cancer, but in particular, a lot of the nursing diagnoses that would be appropriate, would it be appropriate for all? When we think of the side effects, the immunosuppression that happens with the cancer cells attacking the body itself, and then when we look at the side effects for chemo and radiation, we see a lot of, glaringly the risk for infection, risk for bleeding. Of course, there's imbalanced nutrition, less than body requirements, that certainly could be a problem. There could be chronic pain, and then, impaired oral mucous membranes, depending on what type of chemo, of course, if radiation anywhere to the head and neck. Again, so some of it is really dependent on that individual. And then all of the psychosocial stuff, the anticipatory grieving, the altered family processes, etc. There's just a lot that goes into cancer care and cancer treatment that unless you've actually experienced it, I think it's tough to really fully understand, but we always want to try to put ourselves in that patient and family's shoes and think about how we would want to be treated, how we would want to be talked to and supported, and are we giving them all of the resources and tools that they need to be successful and to really successfully work through the process. So with regard to risk for infection, just kind of highlighted some of the things that I feel like we already have such a good foundation, but this is the most common cause of death in an oncology patient. They can get so immunocompromised that infections will take over. So just checking the labs, the white blood cell, the nadir is basically the time of greatest bone marrow suppression. That's basically the lowest point. So that can usually be approximately 7 to 14 days after the initiation of chemo where they reach this lowest point. So obviously this is where the double checks are coming into play, where we are checking the absolute neutrophil count. Remember, that is the number of mature neutrophils that we have to fight the infection. So the number of actual fighting white blood cells that are available. That will tell us a lot about that patient's risk for infection and know if they're going to be able to tolerate another round of chemo that day that's going to further decrease that. So that's the decisions that the pharmacist, the doctor, and the nurses are going to be working on looking at together. Again, there are different bone marrow stimulants. We talked about the filgastrum. Filgastrum is the generic name for Neupogen. And again, there are other, versions of that. We've seen some of the commercials on TV for that. But those can activate or stimulate the growth of neutrophils. Obviously, we're going to be monitoring for signs of infection, fevers, vital signs, other non-specific signs, especially for our elderly, confusion, change in LOC, neutropenic precautions, which we'll be talking about, again, protective isolation. These are all of the things we are doing to protect the patient from any risk of infection that we might have and or visitors, etc. So you do not need to know how to memorize calculating the absolute neutrophil count. This is just showing you that we're looking at the mature neutrophils, which are the segs, and the immature neutrophils, which are the bands, and they're calculating this out. Again, we talked about that absolute neutrophil count being very, very important to determining the real risk of infection. It is determining the total number of white blood cells that are able to fight. And here are the numbers. Again, while you don't need to memorize specifically the range, hopefully we would understand that an absolute neutrophil count, the normal, is between that 1,500 and 2,000. So anything less than that is putting them at risk. The lower the absolute neutrophil count, the worse it is. So if we see like a ANC of 500, that would be hopefully very recognizable that that patient is at very serious risk of developing infection. So again, these levels will be drawn when we have serious events going on and we're getting treatments for our cancer. So they'll be looking at, our absolute neutrophil count, will it be expected to go down after chemo, after radiation? And it'll slowly rise back up, but we're going to definitely be looking at that with each infusion to see if that patient is going to be able to tolerate it or if they need to wait, skip a week, and then do the next week once they're able to build it back up a little bit. So remember, there is a very nice table in your book talking about neutropenic precautions, as well as I have the slide back in the HIV area. But private room, making sure that we're hand washing, that we are wearing a mask, that visitors are wearing a mask, that we don't have sick visitors, not being exposed to a lot of children that, while they may not be sick, tend to carry more germs, avoiding stagnant water, so changing out water containers every shift, not having flowers with stagnant water, making sure that we don't have fresh fruits and vegetables that can have tiny microbes on them. So those are just some of the things that we are definitely paying attention to with neutropenic precautions, or what we call protective isolation. With bone marrow suppression, risk for bleeding and low platelets is also something that we are looking for and that we are basically being proactive in treating. So checking for bleeding, checking the mucous membranes, especially for any nosebleeds, bleeding in the gums when they brush their teeth, obviously any excessive bruising, any blood in the stool or the urine. Again, watching the trending of those labs, and again, platelets, normally 150 to 400,000. Obviously, we're going to expect platelets to be down with cancer treatment, but we don't want it to be so low that there's such a huge risk of bleeding. So you can kind of see the mild, moderate, and severe risk of bleeding. That mild risk in that 50,000 to 100,000 range, and then obviously it goes down from there. So the lower the platelet count is more risk of bleeding to the patient, right? Platelets are clotting factors, or provide that clotting factor. So if we don't have as many platelets, we're not going to clot as easily, which means we're going to bleed more easily. So bleeding precautions. Other labs, if hemoglobin and red blood cells and hemoglobin hematocrit are also low, they may need blood products to build up that hemoglobin level as well. Obviously, we can give actual platelet infusions too. If platelets were extremely low, we could also do that. Bone marrow stimulants that might be applicable here. We talked about that EPO-Eton alpha or the Epigen, and there are some other versions of that as well. So there are some nice tables in your book for taking care of the patient with thrombocytopenia, preventing injury, preventing bleeding, preventing infection. And this is just another nice memory notebook on the bleeding precautions. And again, we've talked a lot about this with patients on warfarin and other people that have bleeding risk, but it's just a nice review. This should be very fundamental information that you just know very well. Other nursing process items that we really look at with the patient with cancer is actual impaired skin integrity or risk for impaired skin integrity. So we always want to do a thorough assessment of the skin. We want to ask patient questions if they're coming into infusion therapy, if they have any new or changes, new impairments or ulcerations to the skin, any changes. We want to ask them about any mouth sores, stomatitis, things like that. Again, if they do have stomatitis in particular, we're going to make sure that we don't have acidic drinks. We're going to use a soft toothbrush or sponge to do cleaning, do mouth rinses, etc. If they're having issues with skin, just the general mild soaps, lotions, loose fitting clothes, etc. They may need topical ointments as well, but we would want them to be guided by their physician and by their oncologist. As far as disturbed body image, that definitely may be a possibility with weight loss, muscle wasting, but then in particular with hair loss. So that can be something that's really tough to see yourself without hair. That really changes your look, your image, and can be very scary for yourself and for others, and especially children, kind of very scary for them if they see grandmas, grandpas that just look very different, or moms or dads. So again, we have the Look Good, Feel Better program, the American Cancer Society, that can help provide these services as far as wigs and things that can help patients feel more comfortable and kind of prepare. The other thing that's interesting with chemo is that once you lose the hair, of course it's going to grow back at different time frames, but usually you begin losing it 2 to 3 weeks after initiation of treatment, and then that regrowth usually begins about 8 weeks after the last treatment. But again, that can vary at the speed at which it's going to grow. But one thing that seems to really happen often is that it grows back very differently. So if you had brown hair, maybe it grows back blonde. If you had curly, now it's straight, or vice versa. So there definitely can be changes in color and texture and even curliness or not curly with the regrowth. So we want to talk to patients about that just so that they kind of know what to expect. Some other priorities then with cancer care, the imbalanced nutrition, less than body requirements, because nausea, vomiting, diarrhea, some of those GI symptoms are very common, and nausea and vomiting being the most common side effect for chemotherapy. We definitely want to do weights. We will definitely do weekly weights when they come into infusion therapy, but we'll encourage them to really track their weights at home as well, same time, same scale, same clothes. We'll have a dietitian involved. If in some cases, we'll have them monitor their caloric intake if it's real bad, but mostly we'll just have them choosing healthy choices and making sure that we're adding enough calories and protein, etc. Labs that would be pertinent, in particular the albumin level, which is 3.5 to 5. We'll want to be watching that because we don't want somebody to get so protein malnourished that then they end up with the muscle wasting. That's not going to help them with their recovery. It's not going to help their body with healing. So we want to really try to keep that protein level up. Monitoring for cachexia, again, that's the muscle wasting, or we say some people undergoing cancer care look emaciated, they look very, very skin. I mean, they're like skeletons, and so they have very, very little subcutaneous. The muscles are just wasting away. So all of those things we would assess and then document for changes. Of course, pain management is certainly a high priority for cancer care as well. 60% of cancer patients have pain. So we need to really ask them specifically the site of the pain, the intensity, and any other associated symptoms, and do a very full, thorough assessment of their pain and try to manage their pain as best we can. It gets a little tough because if the cancer pain is chronic, the addiction with opioids, if it's going to be a longer term use. So there are some things to consider with that, and that's going to be individualized based on their prognosis. If it's a poor prognosis, it doesn't matter if they're becoming addicted to opioids. We want their quality of life good and we want them to have the opioids. But if it looks to be that there is a real good chance of success, we're going to be a little more careful with that because we don't want to, in the meantime, with treating their cancer, have the patient become addicted to opioids. Fatigue is definitely a significant problem with the immunosuppression. We know that our body needs rest in order to heal. We know that fatigue is a protective function, and so we need to listen to our bodies. If we were ill for whatever reason, and certainly if we're undergoing treatments that cause the immunosuppression, we need to rest. We need to get periods of rest and plenty of sleep. Psychosocial status, of course, there could be, like I said, anticipatory grieving, altered family processes, all of these things that go into the mood, the emotional reactions, stages of grief, and all of that. So we will definitely get hospice involved when that would be appropriate if the patient is wishing for that. We'll at least give them all of the information so that they can make an informed decision. We already talked about the body image. There might be hair loss, weight loss. There might be more disfigurement with the surgery itself, such as removal of breast tissue, etc. So lots of things going on that could alter the body image and the self-esteem and well-being of the patient, and just the reactions of family members as well. Some of the oncological emergencies are listed. Sepsis can definitely be a problem. Again, it's one of the leading causes of death for our cancer patients. DIC is disseminated intravascular coagulation, and this is the body is using up all of its clotting factors, and there is inability to coagulate properly. So that could be a possibility as well. Hypercalcemia, and again, looking at the bone destruction, especially if there's bone metastasis, the calcium being lost from the bone is a possibility for increasing blood calcium. SIADH, syndrome of inappropriate antidiuretic hormone. We'll be getting more to these sorts of things with our endocrine unit. That may be a possibility. This is where they have an increase in the antidiuretic hormone, so they have water retention. So increased water retention is possible. Spinal cord compression, superior vena cava syndrome. This can be caused by obstruction of the superior vena cava via either a clot or infection, or something like that. And then tumor lysis syndrome. And this produces a variety of metabolic type abnormalities. So again, these are really pretty specific to this specialty area. I don't think that we have to be experts on all of these things, but again, hopefully we can sort of be familiar with some of the worst case scenario things that could happen in the oncology area as far as emergencies go. Just a nice slide reviewing the age-related changes that and how it can affect the patient with cancer. So the obvious: impaired immune system, decreased T cells, B cells, and all of that, decreased response of that specific immunity, altered drug absorption and distribution and metabolism, and the elimination of these drug metabolites is super critical, especially with chemotherapy. Increased prevalence of other chronic diseases. Do they have other chronic diseases that cause pain, etc.? Do they have impaired renal or cardiopulmonary systems that can impact their ability to respond to an illness of significance like this? Again, what does their skin tissue look like in general? Are they diabetic? Where is their baseline? Did they already start at 90 pounds soaking wet, and we already kind of have impaired nutrition before we get going? A lot of that can impact. Decreased musculoskeletal strength. We know that as we age, there's going to be less strength, muscle mass declines, range of motion declines, so those things can impact. And then if we lose more, we don't, like I said, we don't even have a really good starting point, or we may not have a good starting point to begin with. Again, the changes in cognitive and emotional capacity. Do they have dementia? Do they have forgetfulness or other cognitive impairment? And then, it is realistic that they can get some of what they call chemo brain, where they have, just a change in their cognitive function and thinking process, even in a patient without dementia. So these are things to think about. The correct answer here is D. We would like to give prophylactic antiemetics before meals that may help with their intake. The correct answer here is C. Many chemotherapeutic drugs function by interfering with the DNA replication associated with normal cellular reproduction, or mitosis. The normal mitosis of the stratified squamous epithelium of the mouth and the anus result in their being powerfully affected by the drugs because of this. The correct answer here is B, susceptibility to infection. Again, it doesn't really matter if it's whole body radiation, or if it was Hodgkin's disease or leukemia or any other form of cancer in here. The main thing is just to understand with radiation, with chemo, or any cancer, that the susceptibility to infection is really the most important. So that depression of the bone marrow, which reduces the white blood cells, and the absolute neutrophil count, which can show exactly how many fighting neutrophils we have. Assessing the patient needs for cancer rehabilitation are very important. We'll do a full assessment of their functional assessment. Are they able to return to work if they're of working age? What are their activities of daily living? What can they do for themselves? What might they still need help with? Again, chemo and radiation can take a lot out of a patient on top of the actual cancer itself. And so we have to really kind of reassess what they can do, what they can't do, what services might be available to them, what family might be available to help out and help them with reducing what they need to do on a day-to-day basis until they can build up their strength again. Physiological, of course, we've talked a lot already about nutrition. Some patients may need enteral or parenteral nutrition, so that is a possibility. Elimination, again, especially if they're taking pain medications, there's that high risk of constipation related to the opioid use, so that might be something that we need to address. Again, other symptoms related to the disease itself or treatment, in particular the nausea, vomiting, and pain, and the medications that we can help with that. Psychosocial resources, of course, are very important for the patient and the family, making sure that we get them all set up with the American Cancer Society and other areas of support. There's a lot of community resources such as transportation to medical appointments. There are lots of visitors that can just come into the home and do visits to patients that are in need that may be more homebound because of cancer treatment. Again, we can also get them in touch with either the palliative care nurse or the hospice nurse. And again, this link does go through palliative care, and we will talk about the differences between hospice and palliative care. We'll be talking about hospice, so I just want to mention that palliative care also includes a team of nurse, doctor, social worker, pastoral care, and this can be any patient, independent of the prognosis, can qualify for palliative care. Hospice, you can only qualify if the physician has determined that the patient likely has a 6-month or less prognosis. So there's specific criteria there. They do a lot of the same things, but the palliative care doesn't matter. It doesn't matter your lifespan or the projected or whatever. It's just basically committed to helping patients with how they're going to deal with things. How are they going to feel? What sorts of resources? What are their treatment options? What are some quality of life things? What are some things that are going to change? So just that extra support on managing side effects and all of the things to help them be more comfortable during their cancer care would fall under the palliative care. Doesn't mean care that, oh, they're going to die and end of life care. It just means palliative care. So there are some differences that I just wanted to explain because sometimes people think they are the same and they actually are not. Again, the goal of hospice is definitely ultimately comfort and care, pain control, and having the best end of life as possible. They're going to qualify if the doctor perceives that patient to have 6 months or less. And again, they qualify for hospice not just for cancer care, but they can qualify for hospice with end-stage COPD, end-stage renal disease, end-stage heart failure, or many, many other types of conditions. So they're diagnosed with a terminal illness, a life expectancy of 6 months or less, and this is where they will fit. Now, if they don't pass away in 6 months, they're not dropped from hospice. Of course, they still feel that the prognosis is going to be soon, and so they are going to continue on with their hospice care. Again, if you're really interested in hospice and oncology care, RNs are working in this area, doing the case management, going to the nursing homes, assisted livings, and homes to help other staff and family members with the hospice care as well. I remember when my grandma was on hospice, and the RN that came was so wonderful to both my grandma and our family. So she really helped coordinate and make sure that everything was in order, did a lot of teaching and training of the staff at the assisted living facility too, which was very much appreciated. She was always only a phone call away, which was really nice. This is the philosophy of hospice, and again, we can really be gifts to our patients in this setting if we are working with patients at end of life. And again, in certain settings where you're working with the same patients over and over again, you do get very close with the patients and their families. And so it really is, it's not for everybody. Some people have a lot of difficulty with the death and dying process, and that is too difficult for them to watch as the provider, as the nurse. But for some people, it is just exactly the right fit, and they have that care and compassion to help during that just very important moment for the patient and the family. There are many end-of-life resources. These are just a few links, but you can Google and find many areas of resource. And again, we can provide these sorts of resources to our patients as well. I thought this was a really good time to just review the stages of dying. And again, while we're talking about cancer care here in hospice and the dying process, we're taking care of patients that have died in other areas of nursing, whether it's an expected or unexpected. There's all sorts of situations that we're helping patients and families through this grief process. So, I just wanted to remind everybody of the stages: the denial, anger, bargaining, depression, and acceptance. So denial is just what it says. There's denial. It's an adaptive response. It's a normal defense mechanism. It provides a buffer after bad news. So denial, and again, the time frames at which people are going to go through these vary, but there is a certain period of denial that's going to happen. Typically after that, it's anger. Why me? Why my family member? For some people that are have a lot of strong faith, may also be angry with God or their higher power as to why they would allow this to happen. Bargaining is just wanting to see, my grandchild's birth, wanting to be there. Terminally ill patients are sometimes really looking for that bargaining of just, if I do this, just can I get this and a little more time and whatnot. Depression, of course, is just very normal and an adaptive response. Not everybody who is going through death and dying goes into clinical depression, but we definitely want to be assessing for clinical depression and the need for antidepressants and mood management if that is pertinent. Again, it's a normal process, but we want to make sure that it's adaptive and that it's a healthy version, if you will, of depression, where they're not going to go further and further down. And then acceptance, once people have reached that acceptance, and not all people do reach that in the dying process, but that would be ideal in the ultimate, where the patient can basically, the patient and the family can feel, I have no regrets, I've lived a good life, I've done the things, I've said the things I wanted to say. Any of those sorts of things we want to try to help our patients and their families achieve, because ultimately acceptance would be that final outcome and expression of emotion that we would want. The correct answer here is D. Again, nurses need to be truly present. We certainly will use therapeutic communication, but silence is super, super effective. It permits that client to direct the content and extent of their verbalization. It allows them to vent, allows family. Silence and active listening and really, really making sure that you're silent for a long enough period is a super important skill I have found, especially for oncology, nursing, and other difficult times. The correct answer here is B. The correct answer to this question is D, asking for additional medical consultations. It's very common in that first stage of denial. A would be an example of depression and deep pain. B would be an example of the anger phase of grief. And C would be another example of that depression stage of grief. This is just some things that I have summarized as far as discussing end-of-life care, how we can word some of these very difficult things. So take a look and think to yourself, how would you initiate discussions about end-of-life care, about choices, about what might be important to them, if they have spiritual needs, what do they want that to look like? Who do they want to be present? When do they want family members called? All of those things need to be discussed. The best plan that we have, the more details in that end-of-life care plan, the better it is for all of the healthcare workers to really carry out that plan as the patient and family had wished. These are just some bulleted areas of things that we might assess and ask more questions about. So disclosure, truth-telling, are there any topics that you and your family are uncomfortable discussing? Tell me how you or your family talk about very serious matters. Decision-making style, I think it's important to ask, how are decisions made in your family? Who would you like to be involved in your decision-making? Symptom management, acceptability of medications that they may be offered. What are their beliefs about medication management? Life-sustaining treatment expectations. Have you thought about what type of medical treatment you or your loved one would want at the end of life? Do they have an advanced directive filled out, and has it been reviewed recently? Those are all things that would fall under there. Desired location of dying. Do you have a preference about being at home or in some other location? So again, patients and family will make decisions regarding that. Spiritual religious practices. Is there anything that we should know about your spiritual or religious beliefs about death? Did they want to receive last rites if they were Roman Catholic, for example? Care of the body after death. Is there anything that we should know about how you would like the body handled or treated? Again, we find out the specifics as far as if they're having a certain funeral home that they've made arrangements with, and all of those things we have on record for when that happens. We already know kind of who to communicate and who to notify as far as care of that body after the dying process. Expressions of grief, what types of losses have you and your family experienced? How have those been expressed, and how can we help you? Funeral and burial practices, again, what is their plans? Do we have a certain location and arrangements that have been made? And then mourning practices. It is nice if there are any cultural considerations about how they want to mourn and how they may want to express that when the time comes. Dyspnea is a very common symptom that patients will experience at end of life. So I have a separate slide just on this. Obviously, we want to treat any underlying pathology. If for some reason there is pathology where bronchodilators and steroids would be appropriate. Otherwise, we really want to just medicate to help with their symptoms and their feeling of dyspnea, such as opioids. Opioids are going to relax the bronchioles, help with that breathlessness or that feeling of breathlessness. Again, reduce the respiratory demand. We want to teach energy conservation. We're going to help them be in a position that's going to help with their respiratory drive as best as possible. And ultimately, we want to keep them comfortable. We want them to be breathing as, quote, as normal as possible during that stage. And usually opioids can help with that. They may also need medications to help reduce secretions, and we do have medications such as atropine and other types of similar type medications that can reduce the secretions so they're not having that gurgling sound. While the patient is probably not likely uncomfortable with that, it can be quite bothersome for family members who hear all of those extra secretions and worry that their, loved one is choking, on their extra secretions. So if you haven't been present with somebody at a near-death time, you may not know and be familiar with signs of approaching death. Some of you who have experienced this or experienced this many times know that it certainly is individualized for everybody, but there's a lot of the same signs and symptoms that do happen, and typically in kind of some of the similar sequences. So I have listed many of them. I'm not going to read through them, but I do want you to be looking and understanding that these are some of the things that we will be watching for. These are some of the things that we want to make sure we talk to families about as normal signs, expected signs of this point of their end of life. We're not going to make any families ask all the time, how long do you think he or she has their loved one? We're not going to make any decisions on that. Hospice nurses, when they do this more often, are going to be a little more direct and, indicate that, I do believe it's probably going to be within the next 12 to 24 hours. That's really great. But again, because families are asking because they want to know if they should call other family members, etc. But as RNs kind of in the hospital setting, got to be very careful about how we're going to answer that. And it's not that we're avoiding their questions, but we would just say, it's very difficult to answer that, but I do notice that the urine output, they're not producing much urine anymore, so that is a sign that the kidneys aren't working very well. We do notice a definite change in the respiratory rate pattern, oxygen saturation. Maybe we notice mottling on their extremities. We can explain what we're seeing and what that actually means without necessarily giving a time frame. So that's usually the approach that I will take. One thing, of course, that I want to make sure is that many people at the near death may see things. They may see gardens or special places, family that they have died. So it may seem like they're hallucinating, and they're not actually hallucinating, but they're actually having these visualizations at the very end when they're kind of transferring out of their body. So that's very cool, I guess, that they could actually have this experience at that time, but just so that you're aware. Also, the moaning sound doesn't necessarily mean pain. It may mean pain, but again, many times there's a little bit of moaning or kind of a grunting noise because of that's just the sound of the air passing over very relaxed vocal cords. So some of the sounds don't necessarily mean pain. And we just have to do our best to try to assess the patient, compare it to their baseline, see what family members are thinking, and then go from there. This is what the skin modeling will look like at end of life. It's like a purplish, red-blue. It's one of the later signs of death that is nearing. So definitely can see a very obvious skin change, very significant reduce in blood circulation, and you'll see it on the soles of their feet first, and it'll just work their way up the leg. And of course, their feet and everything is very, very cool, very faint, if at all palpable pulses, etc. And the last slide in this unit just goes through the post-mortem cares. So again, find out what the plan is, talk with family, be prepared for the stages of grief with the family, be prepared to prepare that body and have it welcoming and viewing situation for family. We'll bathe the patient. Again, we'll check to see where the jewelry is supposed to go, make sure that it's documented, that's given to family, etc. We'll remove any lines, drains, etc., IVs, catheters, NG tubes, all of that. We'll cover any wounds that are needed. We'll do the mouth care, put dentures in so that their facial symmetry looks appropriate. We'll close the patient's eyes, and then typically we'll place a rolled washcloth under the patient's mouth to keep it closed. As rigor mortis sets in, we want to make sure that their mouth doesn't stay open as that stiffness sets in. Change the bed linens, the patient's gown. We want everything to be nice and clean, smelling clean. Make sure clean up the room and have everything just really perfect for when the family is going to come in. Every facility will have a policy and protocol for postmortem care, so you'll have a checklist, if you will, as well as different record of death and other forms, and also a policy at the facility if it's going to be a coroner's case, so if there's going to be an autopsy performed, and as well as organ donation. So lots of things that are happening. It's a busy time when a patient or a resident passes, but this is just the general cares and getting the body ready for viewing, and then there'll be another list of all of your end-of-life things as far as, like I said, calling the funeral home, coroner's case, transplant, questionnaire, or organ donation, and those sorts of things. So make sure that you know your facility's policies, bottom line.